Welcome to the AIRP LEND seminar series with a focus on the Health Systems and Services Research Node. This video provides an overview of systems level strategies being used to improve health outcomes for autistic youth and adults with the emphasis on care coordination and transitions. My name is Lindsay Shea, and I am a co-leader of the Health Systems and Services Research Node with Dr. Paul Shattuck. I am the director of the Policy and Analytics Center based at the A.J. Drexel Autism Institute at Drexel University, and I am a white woman with long brown hair. The learning objectives today are to summarize the Autism Intervention Research on Physical Health, or AIRP, program Health Systems and Services Node, to identify a systems level strategy that could improve care coordination and/or transition services, and explain the current research agenda for the Health Systems and Services Node. The Autism Intervention Research Network on Physical Health, known as AIRP, is a project that establishes and maintains an interdisciplinary multi-center research network. It is supported by the Health Resources and Services Administration, or HRSA, and the National Coordinating Center is located at the University of California, Los Angeles, and is led by Principal Investigator of the AIRP, Dr. Alice Kuo. There are 6 primary research areas within AIRP that are called nodes, led by known researchers in the field. The 6 primary research areas include primary care, services and quality, gender, sexuality and reproductive health, neurology, community-based lifestyle interventions, health services and systems, and genetics. The AIRP provides a forum for scientific collaboration and infrastructure to increase the life expectancy and quality of life for autistic individuals, particularly for underserved and vulnerable populations. The purpose of the AIRP is to support innovative life course intervention research that promotes optimal health and well-being of autistic individuals across the lifespan. AUCD, the Association of University Centers on Disabilities, serves a key role in managing the overall functioning of the AIRP network. With AUCD's network of 143 interdisciplinary centers that bring together both university and community resources to achieve meaningful change, the AIRP network is poised to be highly successful in this partnership, delivering stakeholder-driven research and health promotion to autistic individuals and their families. The network of researchers also includes 15 coordinating research entities, or CREs, all of which have LEND programs. The Health Systems and Services Research Node is represented by the JFK partners at the University of Colorado School of Medicine, which have LEND, USED, and DBP programs. And now a general overview of the Health Services and Systems Research Node within AIRP. We know that autistic individuals and their families characterize their experiences as a lifetime of difficult transitions, and that this is due to a number of service provider and resource limitations and barriers. Population level outcomes, as they have been measured among young adults on the autism spectrum, are poor. And that is across physical health, mental health, employment, post-secondary education, community and social participation, independence, financial security, and access to the community services that we know that these individuals report that they need. Systems level strategies for improving policies and programs are needed to improve care coordination and service models to make a change in these outcomes. Specific research priorities include supporting healthcare navigation and models of transition practices, training primary care providers in the adult health system about autistic individuals to understand and identify their needs, as well as to address them, and educating individuals and families about transition care. What does it look like as individuals age? For LEND trainees, the focus of this research node is more on systems and policy at the community-based or population levels, rather than individual levels, such as individuals' assessments and services. This lens lets us really leverage and embark upon seeking population level policy change to improve the outcomes that have remained poor for this group. The Health Systems and Services Research Node has identified several gaps in the research focused on physical health needs of autistic individuals. By addressing these gaps, we aim to improve systems navigation supports and opportunities for autistic youth. We have emerging navigator models, including peer-based navigation in communities as well as in healthcare, that individuals can leverage to access services that they need. We plan to expand existing modules for healthcare navigation and skill development for the autistic population, and considering the use of social network analysis for measuring care coordination. We aim to improve access to healthcare by examining gaps in Medicaid enrollment and service access within the Medicaid system, by examining national population level data that allows us to understand across dimensions and across systems how people are accessing the care they may need or not, and if they are utilizing the services that may support their needs. We also aim for policy impact and cater dissemination strategies, making research accessible, understandable, digestible, and usable. Our goal is to identify transition-specific healthcare needs, emerging conditions. We know that as individuals age into adulthood, there is an onset of a wide variety of medical as well as mental and behavioral health conditions. By understanding the emergence of these conditions, we are more readily able to act to put in place policies and programs that individuals need. We look for supports across the life course, and that linkage across the lifespan, which tells us that experiences in childhood inform transition age youth, and that informs later adulthood outcomes, means that we must study these outcomes across all of these age brackets in order to really comprehensively identify the experience of these individuals as they age. We are examining options for service delivery and health risk assessment models, such as screening tools that are deployed across state Medicaid programs that serve millions of individuals with disabilities, with the responsibility for their health and safety. And how are these health risk assessment models linking them to services and supports that can help improve their health outcomes and prevent adverse outcomes? The top 3 activities identified for the Health Systems and Services Node include healthcare navigation for adolescents and adults and models of effective transition practices, including both the healthcare system and social and community environments, and the use of peer support models. We also are examining training primary care providers in the adult healthcare system to serve autistic individuals and educating families and individuals about transitions and adult care. In March of 2022, in a pediatric supplement, Dr. Alice Kuo, the director of the AIRP, described the prioritization of this research agenda for each node, and that these transitions are key to our understanding of physical health outcomes. And now, a Health Systems and Services Research Node panel discussion.
Thank you, Lindsay, for being here and for your long presentation. As the project director for one of the HRSA-funded Autism Transition Research projects, could you share about the models of transition practices you have identified as being effective?
Sure. This is an exciting time to be identifying and seeking new ways that we can be supporting autistic youth as they age into adulthood. We have new models, some based here in Philadelphia, that are based upon the idea of peer support and the transition into adulthood. And the premise of peer support is that as you age and as you are navigating new health or behavioral health or mental health care needs, that connecting with your peers, people who have also aged or are aging through this transition, is a powerful way for their lived experience to help inform steps you might take. Someone who has lived through this, worked through this themselves, is particularly well poised to talk through options that you may want to pursue as you think about your own healthcare needs. And so we view peer support as a particularly promising model. Peer support also has a rigorous research base in both veteran populations and populations with other mental health diagnoses, including serious mental illness. And so there are ways that we can leverage peer support funding and reimbursement that exists, for example, in the Medicaid program, to deploy this service modality for autistic individuals. It has the dual benefit of not only providing support for autistic individuals, but also employing autistic individuals in paid positions that are reimbursed through health insurance to provide this guidance and to value and center their lived experience. So we are very excited about peer support models as models of transition practices that we view as potentially effective, although we do have an evidence base to generate to back that up. We also know that in a very parallel or shared way, when transition models take into account cultural competency and the preferences of the autistic individual, the characteristics of their families, that they are more likely to be successful. When we think of these models as only one set of ingredients or only one particular pathway, they're less likely to succeed in supporting individuals wrapping around all the elements of the transition process that is one of the most tumultuous times in life for all of us. And so when we center the individual, think about individually based assessments, practices, linkages to resources and supports, we will be more likely to succeed in helping people to get to access the services and supports and programs that they need.
Thank you so much. So could you describe a healthcare navigation system for autistic adults and adolescents that's been shown to be very effective?
Sure. So in some ways, we have lessons that can be learned from overseas in this regard. We know that there are systems in place that provide for quote unquote universal healthcare, social safety net programs, that individuals have data that can be linked across systems that help to determine when there may be, for example, a drop off in education services, when an individual is aging out of the education system, and proactively facilitate new services and supports to come in to supplement or replace the services that may have been needed through that system that they can no longer access. And so we have some takeaways that we can learn from these international peers in terms of how best to take their very effective systems and implement them here in the United States, how to break down the silos between our medical, education, and social programs, and think about more enmeshed views of people's experience so that we can be helping and supporting them and their families as they navigate all the changes that they're enduring.
Thank you. Have you seen these models interact with healthcare systems? And if not, how would you envision that? Or if you have, how do you envision a good system to work?
Mm-hmm. So I predominantly, the focus of my own career is on administrative and claims data. So we often use data from healthcare systems to look at how individuals are cycling through those systems, both by way of their eligibility for healthcare, because in the US, people can disenroll and not have access to healthcare. And then when they are enrolled, how does their service constellation change? Is it based on what they have access to, what's in their community or not in their community? Is it based on social determinants of health that might be impacting their ability to access what they need or what might be around them? And I think one of the ways that data from these systems can be most helpful in the interaction with healthcare systems is through what we are now seeing as the preponderance of electronic health records. That these are set points where clinicians are having interactions with individuals, capturing clinical information, putting assessments directly into electronic health records. And when we can, again, take a linked view of their healthcare experience with electronic health records, with administrative or claims data, with self-reported quality satisfaction data, we can get a more robust understanding of where the model, where our healthcare system is doing well, models that we can take and do more of, versus places where it is falling flat, where it is not meeting the needs of the individuals who need to be served, and where we need key catalysts and incentives for system improvement.
So, is there an issue with HIPAA compliance if you take evaluations from healthcare systems and kind of integrate them within the Medicaid data?
There's always health information protection, privacy is front and center in how any of this research would be conducted and or how any of this clinical practice or program execution would take place. Identify key points. For example, we know that as individuals are being discharged from a jail or a prison, that it's a particularly sensitive window where health is needed the most. And so when we can link up data across systems, it can be particularly helpful in identifying experiences of vulnerable populations. But the autonomy of individuals to make decisions about their healthcare information and how it will be used is absolutely a priority, both in our federal and our state laws. And so those processes and procedures are always steps that are necessary within research and sometimes are not possible by way of making data linkages.
Now, could you please share your experience measuring the effectiveness of care coordination?
Absolutely. We have increasingly been working with autistic individuals and their families to identify how we can conceptualize the idea of care coordination across groups. So for one family, the care coordination needs may look a certain way. They may need access to change from a pediatrician to an adult healthcare primary care provider. They may need access to vocational rehabilitation supports and perhaps some occupational therapy. For another person, the support needs may be far more intense, and care coordination across multiple systems, multiple services, multiple clinicians can look very different. That family may also have different considerations for how their family shares their values and how they think about their lives together as a family and how they support the autistic individual within their family unit. And so it's important as we learn more about how our nation is growing and changing, that we consider the needs across that range of care coordination experiences. We can learn a lot from other areas in this regard. So for example, there has been a tremendous amount of work for care coordination among youth on very young children on the autism spectrum. And are there ways we can take what has yielded from that research base and age it up and think about it in the transition process and into adulthood? Are there ways we can learn from other quote unquote disease areas such as schizophrenia or even depression, anxiety, other places where we know there are multiple types of care needs that individuals will face, and what care coordination models and strategies to examine effectiveness have worked for them? Among the most important voices, I think, to center in understanding these experiences are autistic individuals and their families. So ensuring that we are deploying care coordination, working with the professionals who provide that service, but also thinking about that autistic individual and is this transition looking as they would like it to is a primary element that will determine the success of care coordination effectiveness.
Thank you very much. Another question, are there promising new systems out there, systems of care that you believe will be implemented to improve the quality of life of autistic adolescents and adults?
Yeah, we have done a tremendous amount of work to understand how the Medicaid system itself functions in supporting, as a system of care, autistic adolescents and adults. We've identified a few key gaps. So we've observed that autistic youth are more likely to disenroll from Medicaid than their counterparts with intellectual disability during the transition to adulthood. We know that Medicaid is likely a needed insurance mechanism for the majority of this population because the services covered by private insurance often do not support the breadth of their behavioral health needs. And Medicaid is the largest behavioral health insurer in the US. And so maintaining access to that system is likely a priority for autistic individuals, but we are failing at keeping people enrolled. We've also done work to understand the majority of autism waivers in the US. Waivers are programs that waive normal Medicaid eligibility rules and enroll individuals into programs that are specially designed to meet their needs. We know that the majority of autism waivers in the US are focused on children under the age of 12. And so when programs terminate at the age of 12, but we know that the individuals continue to have lifelong needs, what do we need to do to support the Medicaid system in increasing the number of programs that are available for these individuals across the lifespan? Is it about creating new programs? Is it about making programs that exist, for example, for intellectual disability available to autistic individuals who may not have an ID diagnosis? There are a lot of questions to be answered, but I think that Medicaid will continue to be a key insurer for this group, given low employment rates, given the service portfolio that Medicaid delivers that is not available in any other system. And so I also believe in investing in how Medicaid functions for this group, because we know Medicaid serves a very diverse group of Americans. And this is a place where we can seek to support autistic individuals who come from a variety of backgrounds, who may need to enroll because they live in poverty or because of their disability status. And so safety net programs, in my belief, is a promising system of care that we need to continue to study and invest in to be available for these individuals.
Thank you. So who do you think are the main individuals who should be involved, who should be at the table in the development and implementation of the various models of care coordination?
Absolutely. Autistic individuals should be front and center in this process. What are their preferences? What are their goals? In what ways can the care coordination process support where they would like to be headed in their life? Families and caregivers and care partners are essential in that journey because they are natural supports for these individuals. They are important, often important, but not always, important relationships in their lives, and provide opportunities, connections to many of the life changes that we all experience, connections to thinking about jobs from the neighbor down the street or a previous colleague. And there's a way that that network can be an important scaffold upon which autistic individuals can grow and develop. I think care providers are absolutely critical here as well. And one challenge with that is that this is exacerbated by COVID, but was already an issue in the demand we put upon care providers in understanding everyone's needs the minute they walk in the door without giving them good tools for assessment. And then where in the world do you link people that's within a half a mile radius that they can get to in order to access the supports that they need? And that takes a tremendous amount of community investment, community mapping. And if we continue to leave these providers high and dry, we are very much in parallel leaving autistic individuals high and dry as well, because we are not giving them duly what they need to support the process of care coordination, aging, and optimal physical health outcomes. And one more would be policymakers. We do not generate research that policymakers can use. Much of our work is, for now, kept behind journal paywalls, although that will change in a few years. And the way that we write research is often not accessible for the people who need it. People in community-based nonprofit service organizations need to be able to take the research that we're producing and implement it into their practice today. And in what ways can we take our work and be more real-time and more real overall in making a difference? That is and should be, I think, a top priority for how we think about our work.
Thank you so much for sharing your knowledge and expertise. I really appreciate it.
Thank you for having me.
Great. Hi, I'm Sandra Friedman. I'm director of JFK Partners, which is Colorado's LEND and USED programs. I'm a white female with gray hair, wearing a red top with a bookcase behind me. Adina, would you like to introduce yourself?
And hi, my name is Dina Johnson, and I am the co-director of interdisciplinary training at JFK Partners. And I'm also a white woman with graying hair. And I have a beautiful mountain scene behind me. Kristen?
And I'm Kristen Kaiser. I am a family discipline director and faculty at JFK Partners, but also I am a parent of triplets who just turned 19 this week. And they all have a variety of neurodiversity. So we have 2 of our children with autism and 1 with Tourette's and OCD. And I am also a white female with blonde hair. I'm wearing a pink dress with a blue top over it, and I am in my home office today.
Well, thank you so much, Kristen, for joining us and being our parent representative for this panel. I just have a few questions to ask of you. Did you understand your role as a parent in facilitating transitions for your autistic children? And what roles did you take on?
Thanks, Sandy. That's a great question. I think I didn't really understand my role at first. And when the kids were younger, I relied pretty heavily on my provider teams to help me understand what that role was. I think I quickly learned that you really don't know what you don't know. And you don't know what to ask. And I think the remedy for that for me in my journey was really looking to other parents and looking to build that support community so that we could really advise each other and let each other know what those questions were to ask. I think I grew to understand that my role during those transition times was it was pretty crucial for me to show up for my kids and advocate for what I thought was best. It can be intimidating at first, but I think over time I learned that building rapport with my teams so that when those transition times came, they really understood that I was going to play an important role in that decision. I think the roles that I took on were, first of all, project manager, right? So I needed to understand budget. I needed to pay attention to schedule. I needed to understand programming and content and be able to manage my subcontractors, if you will. I think care coordinator, really understanding the systems of care and how to work with those different agencies. I think I was operating as chief therapist for my family. So making sure that the interventions that we were participating in were generalizing to other settings and that everybody was on the same page. And then I think finally, one of my most important roles that I still play is emotional support animal. So my kids still hug and love on me all throughout the day when I'm with them. So that's still a really important role for me.
That's wonderful. Okay, so it sounds like, if I'm understanding what you said, you really didn't receive education per se about transition or adult care. Is that correct?
Well, Sandy, I would say that when my kids were younger, I really didn't, I had to seek that information out. I will say that for transition age and adult services, I did receive a lot of education. I think I'm fortunate to be surrounded by professionals and other parents who know a lot more than me. So I have a lot of access to information. But I think what's difficult for even me, who has a ton of access, is how do I interpret that information? What do I do with it? And when do I do what? So while there is a lot of information out there, I don't know that it's necessarily digestible, and it can be quickly overwhelming. I think the other thing is that I didn't expect at this stage to have it to have the emotional toll that it's had on me, in terms of, I've spent a lot of years working with families and talking about the grief cycle and disability, and how, different coping phases and different emotions come up at different times. And I'm always struck that I'm surprised that it's as difficult as it is emotionally when you get to one of these really big transitions. And this has been a really big one, I think, for our family. Being triplets, we don't have the benefit of learning from one doing it and then the next. Everyone's doing it at the same time and in different ways. So that's been a challenge for me. There's a degree of like, oh, here we go again. I didn't realize it was going to be this hard again. I think one thing that has occurred to me at this stage as well, in terms of being this transition into adulthood, is that I think my job has really shifted into being chief dreamer. So it's my job, I think, now to really, there are not a lot of resources for adults, and having to pull together a program or a plan for the future that feels exciting and engaging and has dignity, I think a lot of that still falls on me as a parent. So when I think about my son, Graham, who as an adult has mild to moderate support needs, he's in a transition program with the school district, is really helping the transition team learn my particular son and learn to think outside the box for him. Like, he's not going to want to go group bowling every week. He wants to learn how to code. He wants to learn how to have a friend that he can talk to all day long about Pokemon and Super Smash Brothers. But he still needs a lot of support around emotional regulation and social communication and organization and planning. So really learning a profile of my particular son who, has a lot of intelligence and a lot of drive around certain things, but is missing some of those really key skills still. And then for my other two that are in college, I think it's about really encouraging them to create their own support structure, right? So that's a different phase for them, where that self-determination and that self-advocacy, there's so many more supports and services available in colleges now, I think. But it's not my job to set that up for them. And so one of my children is doing a really good job of accessing those supports and services, and one of my children isn't. And it's painful for me to watch him learn those lessons around, you have to reach out for those support and services to be successful on your own.
So it sounds like it's been quite a journey,
yes,
of ups and downs and learning. Is there something you wish you would have had before that you don't have now, that you didn't have? I mean, is there something you wish that you had received that you didn't receive as your kids were growing up?
Yeah, that's such a good question. I think I had so much self-doubt and was so hard on myself in thinking everything had to happen, at a certain time and in a certain way, when everybody's journey is different. And, we're all doing the very best we can, and that we are the people that know our children best. And our journey and the supports and services that we set up for our child aren't going to look like anybody else's, right? It's going to be very unique, and that's okay. And there's beauty in that. I think I wish I knew that when I was younger and when the kids were younger.
Okay, thank you so much. So one more question or two. So I know you run a wonderful support group for parents of autistic children and youth. And you've been doing it for quite a while. Could you please describe some of the common themes that have come up in your group discussions?
Yeah, so the group is called The Living Spectrum, and I started this group when the kids were in preschool, really just as a way of making friends. and having kind of that support and guidance that I felt was missing at the time. That was 15 years ago, which is crazy to think. So it's really grown quite substantially. I think that gap that exists in the community for that parent-to-parent support is really meaningful to fill. A lot of the things that I see coming up over and over again in our support group, both in person and in our online portion, which is on Facebook, I see a lot of calls for emotional support around people who still feel like others don't understand their child. So kind of that lack of awareness of the individuality of people with autism. And then I always see, calls for support around IEP development, meaningful goal development. Questions around medication for co-occurring mental health conditions. We see that a ton over and over again, just really people trying to understand that that's a process and a journey, not a one medication fits all kind of experience. And then I think the past few years, there's been a lot of interest in information about girls and autism and how that manifests. I think there's a lack of understanding in the community at large for how that looks different and how girls are masking and camouflaging. And then recently, I think gender dysphoria and gender transition support is something that we're seeing a lot of requests for support around that.
Wow, thank you so much. You've provided so much rich information, and I appreciate your expertise and your experiences. So thank you so much for participating as one of our panelists.
Thank you, Sandy and Dina.
So TJ, thank you so much for joining us today. Can you give us a little introduction?
Absolutely. Good afternoon, everyone who's watching. My name is Timotheus Gordon Jr., also known as TJ Gordon for short. My pronouns are he, his, him. I'm currently a research associate at the Institute on Disability and Human Development at the University of Illinois, Chicago, as well as an autistic self-advocate and multimedia artist living in Chicago. I am a king-size African-American male with locks, glasses, headset, a black shirt that says Stage Crew in white text, and gray sweatpants. I'm currently sitting in front of a desktop computer in my office.
Great. Well, thank you so much for joining us today. So our first question for you is, can you tell us about yourself and your lived experience with navigating the different service systems to get the resources you needed?
Absolutely. So ever since I turned 18, for the most part, I've been the coordinator of my own care, even though I will still do research on the resources and services that I need medically. I may ask people who are familiar with autism or similar conditions on where I could go for care and services, especially if the provider not only understands developmental disabilities and mental health, but also Black, Indigenous, and other people of color with autism or other disabilities. And so it's been some successes and some roadblocks, I should say, not failures or roadblocks. For the most part, I've been receiving decent care as far as my primary care doctors. I usually have primary care doctors who make sure I stay on top of my physicals, dental health and such. They usually treat me well with respect. However, I came across some people in medical clinics, or even a few specialists who tend to brush past my explanations of what's going on with me and try to summarize. I understand that, there's a lot of patience to try to get things quickly as possible, but it seems that the experience that they wrote does not match up with mine, because I don't think they took the time to really understand and listen to what's going on with me in particular. Now, for the successful visits, people listen to what's going on. They took the time to figure out what's going on with me, and then they gave me options that I could work with. They also explained the situation to me as best as they can.
Great. So in those situations that didn't go well, what do you think could have been done differently that could have improved your experience, especially with navigating the services and coordinating your care?
One of the things I would have done differently is to research particular doctors instead of clinics. Clinics may be disability friendly, but not always the provider. And also to see if they cover under my insurance as well. I think that's the lesson that I took from the not so successful experiences, the power of advocating for myself and others in getting sound medical care, as well as making sure that you have a sound medical team based on your insurance and also your needs.
Yeah, that's a good segue to our next question, which is, have you been able to find the services that you need, and have you been able to access them through your insurance coverage?
Yes, for the most part, even though at times it may not be the most adequate of services, I realized over the years that the more that you pay for insurance, the more options you'll have to explore good medical services and care. I had better luck now getting services through insurance from my employer than Medicaid alone. So I'm able to find more people who not only provide good care, but also could understand me as an African American and the person on the autism spectrum with a few other disabilities, as opposed to if I would have stuck with Medicaid alone, not as successful. Or I'll probably have to pay out of pocket.
Mm-hmm. Okay, that's helpful. So the National Autism Indicator reports found that Black, Indigenous people of color, children with autism, had lower levels of access to a usual source of care than white children with autism. Were you aware of this difference, and how did it affect services and care? How did it affect your services and care?
Not only I'm aware of the difference between the assets to a usual source of care for Black, Indigenous, and people of color with disabilities versus white people with disabilities or autism in this case, but I'm not surprised. I wasn't shocked at all, even when I read the report. I think because I don't fit the mold of the typical person with autism, especially being African American, a big or plus size or king size African American at that, people may have different biases of me. Therefore, I may not get the care that I wanted or need at the particular time. So with that being said, I strongly believe that medical providers must learn and incorporate cultural competency and intersectionality to their practices. It would help if I could be connected with more BIPOC providers who understand and help people with disabilities. For instance, I had difficulties finding mental health providers who could understand my many factors affecting my mental health, including the biases and marginalization due to being on the autism spectrum, but also being an African American male. So part of addressing the disparities is to not only encourage providers to incorporate intersectionality and cultural competence, but also to encourage more BIPOC doctors, specialists, and providers to learn more about the disability community as well in their practices.
Very, very wonderful words of wisdom there. Well, thank you so much for being with us today. We appreciate all of your advice, and we appreciate you being part of this module. Thank you so much.
No problem. Thank you for having me here today.
As we wrap up this module representing AIRP Health Services and Systems Node, I want to thank our speaker and panelists for the wonderful information and insight they provided. Dr. Lindsay Shea, Director of the Policy and Analytics Center at A.J. Drexel Autism Institute and one of the leaders of this node, focus on issues at the system and community levels that need to be addressed and supported, including healthcare navigation, training of primary care providers, and education of autistic individuals and their families. Some of the important gaps include the need to improve system management, expand access to healthcare, and identify treatments specific to the healthcare needs of an individual, including mental health. She also spoke about the importance of peer support. There are systems in place such as Medicaid and waivers that potentially can be refined and further developed to meet the needs across the life course. She also noted the importance of supporting providers and addressing gaps at the policy level. Kristen Kaiser is a mother of neurodiverse triplets who are now young adults. She spoke about being in the throes of her children's transition from high school. She also developed a parent support group when her children were young, was a LEN trainee, and now functions as the executive program director at a school for autistic youth and children. Kristen also spoke about the many challenges that autistic youth and children and their parents and families face, as well as the importance of strong supports. She underscored that each child brings unique needs and interests. TJ Gordon Jr. told us that he initially did not have much assistance with help with care coordination or system navigation. He has done much of that on his own. He spoke of the importance of having medical providers treat autistic individuals with respect, understand and have interest in their disabilities, and take time to provide clear explanations. He also underscored the need for different providers to understand cultural competence, provide everyone with the same respect, and show interest in each person's individual needs. We had three wonderful presenters, a health service researcher, a parent, and a self-advocate. There were some common themes that they all discussed. Autistic individuals, self-advocates, and their families need to be front and center in all aspects of their care. Resource and support need to be individualized, and there needs to be changes at the system level to address the many divergent needs and wants of autistic individuals.